Hello, and welcome back to another episode of the Gastroenterology and Endoscopy podcast. Today, we're diving into a fascinating topic, Cameron lesions. These are unique medical findings that were first identified back in 1986, and they're closely associated with a condition known as a hiatal hernia. So, let's unravel the mystery behind these lesions and understand why they're significant in medical diagnostics. Cameron lesions are essentially linear erosions or ulcerations. These are found on the gastric mucosal folds in patients who have a large hiatal hernia. This is particularly interesting because these lesions are typically located at what we call the diaphragmatic pinch. They were first depicted by two researchers, Cameron and Higgins, in the mid-'80s. Their discovery highlighted that these lesions were prevalent in patients who had a significant portion of their stomach positioned above the diaphragm, as seen in chest X-rays. Now, you might be wondering, what causes these lesions? The primary theory revolves around mechanical trauma. It's believed that persistent friction between the gastric folds at the level of constriction leads to these lesions, resulting in local ischemia. Additionally, factors like the pressure difference between the thoracic and abdominal cavity during respiration can contribute to mucosal stress and ulceration. Plus, there's added injury potential from gastric acid and the pressure of the diaphragm on the hernia. It's quite fascinating to note that hiatal hernias are identified in a small percentage of patients undergoing esophagogastroduodenoscopy, or EGD. Among these patients, Cameron lesions are found in about 5% of all cases. However, the prevalence of these lesions increases with the size of the hiatal hernia. Diagnosing Cameron lesions is best done through EGD. During this procedure, these lesions are visualized as superficial, linear erosions or ulcerations on the mucosa covering the gastric folds. Sometimes they're accompanied by erythema, edema, or bleeding. But here's a challenge. They're often missed in initial EGDs, primarily because they can be very small and may not exhibit active bleeding. That's why special attention is needed when examining patients with hiatal hernias. Treatment-wise, proton pump inhibitors, or PPIs, are the mainstay. Most patients respond well to this medical therapy. Additionally, iron supplementation can be crucial, as Cameron lesions can lead to iron deficiency anemia. And interestingly, a significant number of patients with these lesions also have gastroesophageal reflux disease, or GERD. To sum it up, Cameron lesions, while rare and benign, are significant findings in patients with large hiatal hernias. They're often underestimated because of their size and can easily be overlooked. That's why a high index of suspicion is essential, especially in patients with large and complex hiatal hernias. That wraps up our discussion on Cameron lesions. It's a topic that beautifully illustrates the intricacies of medical diagnostics and the importance of detailed observation. Thanks for tuning in, and I'll catch you in the next episode.